Hello, this is Eric Topol of Medscape with my co-host Abraham Verghese, and we are really pleased today to have a chance to have a conversation with Dr. Nathan Grubaugh. He is at Yale School of Public Health. We like to claim him as a product of Scripps Research since he did his postdoc here with Christian Anderson. But he has a rich background, biotech at Johns Hopkins. He was at Colorado State, and he has done extraordinary work even before getting into the pandemic. So Nathan, welcome.
Well, thank you for having me. It's a pleasure to be talking to you today.
Well, you have been rocking it there at Yale, and I've noticed you and your colleagues, which span the gamut from immunology with Akiko, who we had a chance to talk with, Abraham and I, with Said Omer, with on wastewater, the work you're doing with Ann Wiley on rapid saliva. I mean, you're covering every base of this pandemic. How are you doing it, and how has Yale come to life?
It's, looking back at this over the last year, it's actually sort of like crazy to think about all the different things that we have done, but it really stems from at the beginning, when going back to late February, early March last year, when a lot of us were realizing about what was going to hit us, but maybe not everybody fully had the appreciation for it. But we just got together as a lot of different labs on the School of Medicine, from the School of Public Health, from the research standpoint, and also with the Yale New Haven Hospital to be able to just provide basic support. I mean, at that time, hospitals weren't even able to do testing because there weren't any tests available. So just like really basic stuff. And it just grew from there. And we started enrolling patients early because there was obviously so much that we needed to know about immunology, pathogenesis, epidemiology. And we just formed this group that's called Impact. And we shared clinical samples, we shared data, and of course, Akiko's been rocking it on the immunology side and gets way in further than what I understand. But it's just so great to be able to contribute to that, and I think that they probably feel the same way on our end with the diagnostics and with the genomic epidemiology.
Well, I think it's a case study of how a university can put together all of its brain trust and transdisciplinary, because, I try to follow what's going on out there. I haven't seen anything like what Yale has done. I mean, and now you're at the center of it, and really appreciate all your efforts. Obviously, you've been a leader in outbreak analysis with genomics. You've been there with Zika and West Nile and other pathogens. And here, I last night I get an email from the NBA, and they wanted to tip me off that a paper was coming out, or a preprint, with the NBA and staff, players and staff, that had B117 compared to non-B117, and kind of shooting down the idea that this was a viral load issue and could be just a clearance and prolonged infections. And of course, I looked at the authors, you were one of them. Can you comment about this? This is a very interesting, it's only, of course, in a limited number of people, although a fair good anchoring with the non-B117 strain. What is your sense about this strain and that finding?
Yeah, this, of course, the N is 7 here, so we have to consider that. But we're finding that the duration of infection, at least by PCR testing, with these 7 individuals that are mostly healthy individuals. These aren't, inpatients. And the duration of infection is between 10 and 17 days. And that's considerably longer than what we had been finding with non-B117 infections that are more in the 7 to 10 day range. And so it forms this hypothesis that perhaps it's more transmissible because you're infectious for longer, not because you have a greater load at any one time. But we do need to look at this in other populations, obviously. But the reason why we wanted to get this out quickly is because this could have an impact on our isolation protocols. And certainly the NBA is looking at this and how long somebody might need to be isolated if you have this variant. And so we thought that it's a good way to get information out there to maybe share with other groups that might be trying to generate similar data, so we can really help provide some guidance around how to control this.
That's really interesting. And, you know, it wasn't the first intersection you've had with the NBA, which is also noteworthy because here, you know, we don't think of sports, professional sports, as contributing to science, but because they have so much money, I guess, and they can do so much testing, and it's vital to keep their players healthy. You were involved with the bubble, with the saliva testing. And can you tell us about what that experience was like?
Yeah, back in, trying to think, it seems like decades ago, but maybe it was April or something. We were working on, we had just put out a preprint with Ann Wiley on comparing nasopharyngeal swabs to saliva and finding that saliva was at least as good for detection as these swabs were. We get a strange email from somebody from the NBA asking if they would be interested in talking to us about this, because they were looking for how to find ways to do testing on players. And of course, when people are getting daily tests, having something that is not as invasive as an MP swab is good. So we had several conversations with them, and it led to this research project that really became what was Saliva Direct. What's interesting about that is, at the time, Ann and I were mainly interested in just telling people that you can use saliva. We weren't really interested in developing our own tests. And they kept on saying, like, well, we'll just use your test. And it's like, well, we don't have one. It's like, well, can you develop one? It's like, well, I guess. And then we started thinking about, like, if we were going to develop one ourselves, what are our values there? And we put that into play. But what was really fantastic about this is, because they were already going to be doing testing on players and staff every day leading up to the bubble, that it was then pretty easy to tack on a paired saliva test for this. And so we ended up testing some 4,000 paired tests between swabs and saliva. And I mean, it was a really large study. And then the funds from that helped us develop all the lab data we needed as well, and the clinical data. So a lot of that went into our emergency use authorization came from the hospital, but this was completely funded by the NBA. And then as the study was going, it turned out they were interested in doing some virus sequencing. And as Dave Weiss from the NBA had been asking around within the group, like, well, who could do this? Like, well, you're kind of working with someone who can do this. And so we started doing sequencing with them, and we became sort of integrated within their epidemiological team, and where there's just so much data that they have, and they've been so open about sharing that and wanting to promote research. And there's a lot of other outputs that I think they're going to come from this, that we've worked with them through the bubble. We've been working with them all season. And what we've learned as well with doing sequencing to identify if cases are related or unrelated. Such a simple but fundamental concept when you're thinking about controlling outbreaks, that, I mean, we've been doing this with them for months, and have hopefully a nice paper on the back end of that describing how this works.
And now those are the sequences that were also that B117 comparison. Yeah.
Yeah.
Abraham,
I mean, that's,
I'm
sorry, go ahead.
Abraham,
I was just thinking, you've done such a remarkable job, Nathan, of getting data, especially from Connecticut, but also much more broadly. But for our listeners who are not as sophisticated as Eric and you, just remind us again, if you would, what makes B117 so special? What makes the South African strain different? And this is actually groundbreaking to think that the B117's main issue is the prolonged duration of infection. It's a breakthrough in our understanding. But take us back to molecularly, if you will, just so we're on the same page here.
Yeah, so B117 has a constellation of mutations that maybe some of them individually, but likely a collection of these that appear to enhance transmission. that we see higher secondary attack rates, faster clade growth from the data that was coming out of the UK on this. And now that we have more data from Denmark and we have data now from the US, it seems like this wasn't just a population effect. This is clearly something that's linked to the virus itself that makes it more transmissible. And also now in the UK, that some of these viruses have obtained the E484K mutation, which I'm the most concerned with, because this seems to have, this has some effect on antibody neutralization. And that's really the primary concern now when we start thinking about B1351, which was first detected in South Africa, and also P1, which was first detected in Brazil and Japan, is that it has these mutations. I don't think we quite know if those variants are truly more transmissible. We are finding them now popping up all over the place. What happens when you have multiple more transmissible strains that sort of like hit each other at the same time in the same location, like that? They can't all be more transmissible, but the fact that some of these mutations or some of these variants carry mutations that could impact vaccines, I think is really the biggest worry of all of this.
And just to follow up to that, it seems like a wonderful act of serendipity that you happen to be testing the NBA players and could get the data that you just showed us on prolonged duration of transmission. But what is the obstacle keeping us from doing that nationwide and having this kind of monitoring? Explain that to us if you would.
Well, one of those obstacles has been partially lifted today with the announcement of $200 million from the CDC to start creating programs. To be quite honest, I think that we had been handcuffed by the previous administration because we didn't put effort into this. And I mean, my lab and lots of academic labs and state labs and such had started sequencing right at the beginning of the pandemic. And I don't think most people, even in public health, really at that time knew the importance of doing this work. And so that was just never prioritized. It wasn't prioritized at the top level, and those funds weren't distributed down to be able to support this work. So we were all supporting it in various different ways. The CDC certainly knew about this, and they gave out contracts. And we have a contract from the CDC that started back in the fall to do more sequencing. But you know, it takes time to build a program like this, and it's not just about money. We have the technology throughout the country to do it. We have the will to want to do it. It's really more of the operational aspect of it, of getting the samples into the right place in the right format that has the sessioning around it. So you can do this at large scale, and then handling the data. So it's not a simple positive or negative. There's a lot of data that goes with this, and it has to be analyzed in a coordinated way. And what we've learned by working with both the NBA and also working with the NFL, doing the same thing with all the sequencing, is that, you know, the devil's in the details. Sequencing's easy. It's getting the samples there. It's getting the right data connected with the samples. It's getting them through the pipeline. It's having the data on the back end and interpreting it. So I think with the funds that are being distributed now, it's to create this program. And it's not going to get us to what 5% or so of the cases that we need to sequence across the country, you know, as that sort of like mark that some people have set for our standard of what we need to reach. But it's going to start to get us there. It's going to create the system to do it. Once we have some more of this established, then it'll be much easier to increase capacity within it because we already have the framework.
Yeah, I think just as far to go on either end of that pipeline, I think it's also to note, firstly, that the sample supply you had from NBA and NFL put you in very good stead. That sampling connects to labs is a big issue.
Mm-hmm.
And also that the reagents have been a bottleneck at times, even at the low level that we're doing. And then lastly, and you touched on this already, Nathan, but this mutation, the 484 EEK mutation, that mutation, which is linked in Brazil, South Africa, as being part of the immune escape mosaic, if you will, it's also been a mutation that's been found in many innocent variants. So it's hard to know when you have this combined with the UK variant, which is obviously one that's highly more transmissible, maybe more lethal. And now if you had the triple whammy, you have immune escape. But I'd like to get your perspective of what we know now. Forget adding this unknown dimension of the recent fusion of a mutation and whether that adds. B117 was bad enough, UK variant. What are we going to do now? Because don't you think that's going to be the dominant strain in the United States over the weeks ahead?
I mean, it's looking like it's trending that way for sure. We're finding that with our data. We also recently posted a preprint showing the establishment of multiple of community transmission throughout the country, and also domestic spread of this now, that we see evidence for spread from New York, for example, into New Jersey, into Connecticut, into Michigan, and the frequency is increasing. Now, is it going to be a month and it's going to be dominant? Hard to know exactly, and it's going to be very heterogeneous across the country as well. But it's certainly heading in that direction. And forget about the E484K for a second. I mean, this could have very serious effects on our healthcare system, and I'm personally worried about my kid's school. Right,
yeah.
It was my 5-year-old, my kindergartner, wasn't in school the entire fall and just went back for first time ever in in-person school in January, and I'm already worried about what's going to happen as community transmission goes back up and we have to close that down again. But even more so is the burden on the hospital system and what could happen there. And on top of that, the fatigue that we all have to go through another peak again. And I know that I'm tired. I know that my team's tired. I can't imagine what the folks are like in the hospital, that working these really long shifts and all the nightmarish things that they have seen over the last year, and to put them through another spike again just seems really unbearable. So there's a lot of things we can do to prevent transmission, and we shouldn't be arguing about whether or not B117 will become more dominant or not. We should just be doing these things just to help prevent that from happening.
You'd think after what we've been through for over a year now, that we'd be smart enough to know to plan for the worst.
Mm-hmm.
And but it looks like now people are being lulled into, everything's going down now, cases are going down, hospitalization, everything, we're done. And I think the cognoscenti know much better, but they can't affect behavior. Is that really kind of where we're stuck in this country? Is that we're just can't get people to be aligned to do the right thing?
I think so. And I really would like for the media to change their perspective around how they're covering variants. Right now, like every interview request that I get is about how we're not doing enough sequencing. And you know what? We've sequenced over 100,000 genomes in this country. It's an incredible feat. We haven't done enough, but it's hard to do. The thing is, we know that they're here, and we know what we can do to slow the spread of them. Now, there are some nuances in this that we might need to consider, like a longer isolation period or something, but there's still just really basic things like social distancing and mask wearing, and collectively doing things that we know to prevent spread. If you know that you have symptoms, like maybe don't go to the grocery store, or if there's really high community prevalence, maybe we shouldn't have indoor dining in restaurants and bars. Just these things that we know that can work. If all of the stories that go from really criticizing our surveillance system and put more towards, hey, we need to be working together. We have, the end is near. There are vaccines. Yes, we wish they could be rolled out faster. But we can all get there if we work really hard now, and nobody wants to have that happen again, and have these spikes and overrun hospital systems.
Medicine and the Machine will be right back.
Welcome to Medscape's latest podcast series, Medicine and the Machine, featuring Medscape's editor-in-chief, Dr. Eric Topol, and master storyteller and clinician, Dr. Abraham Verghese. Remember, you can find the latest in medical news, expert perspectives, clinical tools, continuing medical education, and more at medscape.com.
Nathan, thank you for that. Speaking from the hospital perspective as a clinician, I think you're right. We're all quite burnt out. We're also all fully expecting the surge by late March. But I'm hearing a sentiment from my colleagues, and I hope this is true, that maybe it will be different because we've managed, at least around here, to successfully vaccinate many of the over 75, over the 65 now. What do both of you think in terms of, might we have modified the picture any with the next surge?
Well, I would be really interested in Eric's take on this, so I'm going to let him go first.
Yeah, I don't think we put a dent in the vaccination really yet to make a difference. I mean, it may be a small bit, but when you look at Israel and you see they've countered B117 so extraordinarily well, and then we're starting to see some of that in the UK for the really advanced age over 80. But, you know, we just are at a low level because of our, let's say 12% of our vaccinees in this country, a lot of those were healthcare workers and nursing home residents. So I don't know that we've had enough to even start to make a difference. We do have the background of having a massive spread of infections throughout the country, but I'm not sure how much that's going to blunt this. So I'm quite worried about it. And Nathan, let's get your take.
I'm in of similar mind that, you know, it would be great if we actually did vaccinate enough of our most vulnerable populations where we can maybe escape part of it. And there's still time to do this. Right. Mm-hmm. There's still time to increase rollout, and it's been so disappointing on how slow it's been. But I understand too from like the public health perspective here that the same individuals that are responsible for all the testing and they're responsible for everything else are now responsible for vaccine rollout. You put so much on a small workforce, a small, mainly underfunded workforce, to do all these really important tasks, and we wonder why that things aren't as fast as they could be.
I was going to ask you about that because another thing that you've done so well. So the states that are leading the charge of vaccination are some of the most unlikely candidates, like West Virginia, the Dakotas, Alaska. But right up on the list of the high performers is Connecticut. Is that because of what you're doing in New Haven, or what's going on there?
I'm not actually sure how they're doing so well here. I know many folks in the health department, and I know that there's a lot of coordination and plans to do it. I know the folks that are running from our New Haven health department that I think are just fantastic, and they put so much effort into this, and it's just hard work in having a coordinated plan. But I think that they would tell you as well that they wish they could be doing more.
Yeah, it's been impressive to watch what you've achieved in Connecticut in every respect. Now, another thing that we should be doing everywhere is wastewater surveillance, right? And, you know, you had said, Omer and colleagues published one of a landmark paper in that regard, where you could tell a few days in advance whether an outbreak was starting to emerge. And since that time, there have been papers that have come out that you could even pick up new strains and new variants. So are you doing that routinely in New Haven? And why aren't we doing this everywhere? Because it's so easy and cheap.
Yeah, so first, I think that wastewater surveillance is just a fantastic supplement to clinical testing. We still obviously need the clinical testing. People need their results, but as like a basic surveillance, I look at the wastewater data every day because I think it's just so informative. Now, there are some random blips that come in there because you get something that's more concentrated than not, whatever. But if you look at the 7-day averages throughout it, it's great. And we have here at Yale, led by Jordan Peccia, and then with Dodd as well, that helping to establish this. This is being done in 6 different catchment areas throughout the state. And I think the number of times that I've heard this reference just randomly by people just shows how much of an impact that it's having. Now, variant surveillance here is an interesting thing. I get asked about this a lot. So are we trying to sequence from wastewater to look for variants? Yes. But I will tell you, it's not an easy thing to just to say, yes, we're going to do this. It is, one, even though we can detect virus in wastewater, it's not a lot. This isn't clinical concentration levels. And it's usually, it's down at those levels where, if I'm thinking about my background of intra-host sequencing, where we look at population dynamics as they evolve within an individual, I've taken the same sort of mindset of this for wastewater. It's like, this is a population and we're trying to look for variants. But the amount of virus there, if this was a clinical sample, I would say, we're not even going to try this. The other part of it is that it's wastewater. This RNA is degraded. It's not the easiest thing in the world to sequence from. And when you combine these things together and all the bottlenecks that happen in the lab, where you take a sample and you take part of that sample, then a part of that sample and a part of that sample, by the end, what you have, I'm not sure how many individuals that represents. Mm-hmm. Right? It may not be, even though that this catchment area for wastewater serves 200,000 people or 1 million people, what you have in your sample might represent 200 people.
Right.
So we are trying to, but it can be done. There are ways around it. I'm hoping for maybe even some PCR methods that can help differentiate minor frequencies. But so far we haven't found the variants in the wastewater, even though we know they're in Connecticut. And I think it's because, I think this is going to be a fantastic method once we really improve the method of tracking frequency changes over time. Mm-hmm. But I don't think it's the method to detect it when it's really rare.
Right. So I think what the take I get from you on this is that, we're going to go months from now, fast forward, when we have this virus under relative control, hopefully by the summer. And then we're going to be wanting to know where it's cropping up and in advance before there's a significant outbreak. And it seems like, irrespective of being able to determine the variants, which, you've given us some caveats, just knowing the titer of virus would be helpful. Now, Abraham, do you have wastewater surveillance in Palo Alto?
I honestly don't know, Eric. I was just thinking that. I don't know. I don't know the answer to that.
Because we don't have it here. UC San Diego does, only for their little network community. But, the idea that Nathan can look on his phone and see what's going on each day, and we're in the dark, and this is like, what are we prehistoric here? What's wrong with us? I just don't get this.
Yeah, I mean, of course it's set up in a lot of different areas, but it's not nearly as widespread as it should be. And I think some of it comes from also the skill of collecting the samples and working with it in the lab. I sort of undersell when I talk about this, the amount of work that Jordan Peccia's lab does just to extract RNA from these samples. You get this big sample that you have to condense down and purify many times to actually then get something that is a usable RNA sample for doing PCR. It's not like what we have in our lab, where we just get a tube of saliva and you pull some out of it and you just do a basic RNA extraction. That's easy to do. Wastewater is hard. And I think that's one of the issues, is that it takes investment to get something going. And when there's just so many different things that you could be doing to helping with the pandemic, and actually few people that do it, that maybe this is something that gets overlooked in some areas.
Yeah, well, speaking of hard sampling, anyone who's gone through a nasopharyngeal swab, AKA brain biopsy, would be saying that they don't want to have that again or on a frequent basis. And your contribution with the saliva work has been transformative, because not only what you've done, but now all the meta-analyses surprisingly showed, for some of the naysayers, that saliva was as good or better. So can you amplify about that, and why aren't we switching to saliva? Because still you have every place doing these deep nose swabs, and they're not exactly something that's user friendly.
Yeah. saliva has been amazingly useful, and even Akiko has a paper showing that saliva titers are better correlates of disease outcome than these nasopharyngeal swabs are, which is really incredible. And hopefully we can get that validated in multiple locations, and maybe it could actually be of more use in a clinical setting. But so, I mean, the saliva obviously has a lot of like great advantages here in that. I mean, take my 5-year-old, for example. She had to get a test, and it was an anterior nares swab, so just at the base of the nose, not even the deep one. And they did that to her once, and she just freaked out, and she will not go again. I give her a tube and ask her to spit in it; she'll do it all day long. And the number, like the stories and conversations that I've had with other people about how they were afraid to get tested because of the nasopharyngeal swabs, and now with saliva that they would be willing to do it. So why hasn't it become more widespread? I think one of the major limitations of using saliva is actually working with it in the lab. So a lot of the labs, you would rather have the nasal swabs, which come in this nice media liquid that you just pull the swab out and you vortex it really quickly and you use it. The tubes are set up for the systems. Our clinical labs are used to working with it because this is how we've done things with influenza and other respiratory pathogens for a long time. Saliva takes a little bit more care. There's more variability within the sample, so it's more work to do. And I think that's been the major barrier. But even said that, we are still seeing more and more saliva-based tests that are popping up. They're really popular for home tests or mail-in tests. And there's even some movement about using saliva for influenza testing. And I think that we might see some carryover effects even after we are able to get out of the COVID pandemic, and just for seasonal flu testing. So I think it just takes time to change our laboratory testing systems to move away from things that are well established to make room for something like this.
Going back to your thesis about the NBA, the B117 infection being of prolonged duration, do you think that might have an effect on the nature of the neutralizing antibody production? Does it reflect the fact that it might not be as robust, or might it be more robust at the very end? And are you collecting serum for that sort of stuff?
So to be perfectly honest, I don't get a lot of time to think very critically even about our data. Everything is about generating data and putting together figures and making that available. Just the other day, with a neighbor, I had the longest conversation about virus evolution that I've had in a long time, because it's more about like, do we find something, not about how did this happen? So why is it more prolonged, and does that say something about the immune response to it? I mean, I think it's a good hypothesis, but I don't know. Likely, I'm going to guess that it's likely not due to neutralizing antibodies from my very limited immunology background, and think that it has something more to do with its ability to infect cells. And it might be not causing to increase viral load, but there is laboratory evidence that suggests that B117 has higher infectivity in cells and better binding to ACE2 receptors. So maybe it's just able to get to more places within the body and it lasts longer before it's cleared. But I think obviously there's a lot that we have to learn there.
I just wonder.
Go ahead, Abram.
I just wonder if the corollary to that might not be that this virus, if it becomes prevalent, might generate more robust immunity than we, have been than we've been assuming for the other strains.
I like you looking at the sunny side. That's good. But one of the things that this brings up, this has plagued the whole field of genomics from its origin, and that is we're really good at sequencing, and we're not so good at functional assessment. And that's not just in pathogen. That's like for decades. Now here, this was a unique thing, that the study that Nathan was involved in that you had this frequent sampling every day, where we never do that to understand the phenotype of the virus, right? We never do that. except in this rare circumstance. In fact, we can't even get these transmission studies of the vaccine effects because the companies like Moderna and Pfizer and all the rest of them, they haven't really done the studies we need to do with daily nasopharyngeal swabs. But in addition to that, it's so hard to understand the functional consequences of the sequence changes. So, Nathan, how do you go about that? Because you wrote I think a classic paper on the D614G in Cell, because there the question was that a more fit strain? It wasn't the very original SARS-CoV-2. It was a change that became dominant. And there's been, in the beginning, there was a group of people that said, it's nothing. And then it was a little bit more fit, it's more fit. And you kind of cracked the case on that. So can you tell us about the phenotype, the assessment of the functional changes of a virus sequence?
Yeah, this is, of course, the hardest thing to do, right? Us that are doing sequencing a lot, the observational data is relatively easy to get, and we see things that are happening. Even going back to February with Eddie Holmes and a PhD student in my lab, Mary Petrone, we wrote a paper on why we shouldn't worry when viruses mutate, which I regret the title of that now, actually. But the point of the paper still exists, that it's really difficult to actually determine the effects of mutation, that this is a non-trivial amount of work to go into that. And for most of what we study, when we're studying things that are not like this pandemic that affects everybody's lives, you have time to go through that and to do those assessments. Here, we're in this really tough situation where it's to understand the functional impact of a mutation, you need the observational data. You need of the sequencing data itself to say, okay, we find that this is emerging. We can look at evolutionary pressures. You need the epidemiological data. So, for example, in this case with the NBA, we have daily testing. We can understand, and we understand way more than what we can actually reveal in that paper too about the epidemiology. But we have these temporal sequencing or temporal testing components. You look at the UK, what they've done with B117 and looking at secondary attack rate, and then the serendipitous finding of the TACPath assay having a dropout with this variant allowed you to look at the spread of it as well. Then you have to take that into an in vitro setting. And this is where the Jeremy Lubans and the Akikos of the world come into play to look at neutralization, to look at how this might affect immune response in cells or maybe even in mice, to look at if it's infectivity, growth kinetics, and all these things. And then the last part of it is we need the clinical data. And we need to have enough of this clinical data to make real assessments. It's not just one group that can do this to figure it out. It's so many different pieces of data, and what you are seeing unfolding for all of these different variants is the assembly of all this data to come up with an understanding of what's happening. But what I've really learned over the last year about what public health is, it's making decisions with limited data. And you're constantly being challenged because you don't know everything, but yet you have to put something in place. And so we're constantly changing our minds. We're being influenced by the new data that is arising, but we're having to put things in place and make recommendations up front on that. It's a really challenging thing to do.
Yeah. Well, we could go on for a few more hours because you're a wizard. We just love hearing your thoughts, your perspective. You've been groundbreaking in this pandemic, Nathan. We're so proud of your efforts, and the fact that we could say that you were a postdoc with us at Scripps is something we like to brag about, and seeing all your output. And also, I just want to reinforce what you've done at Yale is a model. I mean, obviously you're collaborating with people all around the world, but you've assembled the parts, and the sum is extraordinary. And we're all watching that, because if every university did that around the country and around the world, we would all get smarter faster. But I just think, we one of our most memorable sessions was with Akiko. I mean, I think early on we spoke with her, and Abraham and I think we had immunology from 101 to 505, and she's like lighting it up out there, and so are you. And so, just to say we're really grateful, because we know this is like 25 hours a day stuff that you're doing, and you and your team. So thank you for all your efforts, and Anne, and the Howie, and every one of you. You're just amazing. So thanks a lot. Thanks for joining us today.
Thank you so much, Nathan.
Yeah, thank you. I really appreciate all the sentiments about that. And I would say that one of the actual bright spots from this past year is to be able to work with a lot of these individuals and really have this strong connection with the School of Medicine and the hospital and the state epidemiologists and the local epidemiologists. There's a lot of individuals that I never got to work with before. And these collaborations now, I think, are going to be really useful for anything going forward. We have this established, we know how to do it, and hopefully others can replicate this as well.
Oh, we sure hope so. Thanks a lot.